So just take a moment just to take a deep breath and just relax. And our little affirmation today is from a book called The Complete Pocket Positives. Doing nothing for others is the undoing of oneself. We must be purposely kind and generous, or we miss the best part of life's existence. The heart that goes out of itself gets large and full of joy. We do ourselves most good by doing something for others. So thank you, everybody, and I hope you enjoyed today's panel discussion. Thank you.
Thank you, Imelda. That's a really nice way to start our meeting, just to focus in on what we're doing. So before I introduce our keynote speaker, I'm going to just introduce the panel and we'll make sure that you all know who everybody is. So the first is Sinead Tighe, who's here. Do you want to stick your hand up? Sorry, yeah. Probably, maybe everyone knows you already. So Sinead is a member of the Tallaght community, and she's going to speak today about her own experience of inequities in healthcare. And she's one of the community representatives in the Academic Primary Care Centre, and we're really grateful for all the support she's given to it over the last year. The next is Aine Lynch, who is the Director of Nursing in Tallaght University Hospital and is also a member of the Academic Primary Care Centre Steering Committee. Suzanne Kennedy, who is a Clinical Nurse Manager in Tallaght University Hospital and is the Intellectual Disability Liaison, which I understand is a pretty unique position across the country. So Tallaught's leading the way on that. Well done. And then Evelyn Reilly, who's a Clinical Nurse Specialist for Dementia and Intellectual Disability and working with the Daughters of Charity and again Tallaght University Hospital. So, and last but by no means least, Trinity's Professor Mary McCarron, who is a bit of a world superstar in research and a national award winner from the Health Research Board. So we're delighted to have you here today as our keynote speaker. Mary is the Professor of Aging and Intellectual Disability in Trinity College and Director of the Trinity Centre for Aging and Intellectual Disability. She's the founder and leader of the first ever longitudinal study of aging in persons with an intellectual disability called IDS Tilde, where her innovative and inclusive approach of involving participants from the design stage of the study has always ensured that the people with intellectual disability are at the very heart of all the research and all the service development that concerns them. She has been a pivotal figure in developing a positive, person-centered culture locally and nationally and internationally. And she's had many leadership roles in Trinity as well, including being the Dean of the first female faculty dean. And she's recognized by her own team as a warm and approachable leader who always makes time for them. And she's an avid cyclist in her spare time. Interesting piece of extra information. And we'll enjoy a cup of tea afterwards with everybody. So do you want to come on up? Thank you very much.
Thank you so much, Susan, and lovely to be here. And it's a great privilege for me indeed to be here today, because I was the Dean of the Faculty of Health Sciences when we developed this initiative and this building, and working with Catherine and other people who were here at the time. And I'm just so pleased that we always wanted this centre to be for the community and to really represent the community of Tallaght and to work very closely with them. And I am based here as well now because I'm also doing a role at Tallaght University Hospital, and we are based here, and I'll speak a little bit about that. People often feel, because my whole lifetime has been devoted to trying to push and address the inequity for people with an intellectual disability. And I often like to say up front, I don't have anyone in my family with an intellectual disability. People often feel that you must have if you're so passionate about it, but actually I don't have. But I've spent a lifetime trying to fight the fight for this population, and hopefully we are making inroads. I just share your screen on Zoom just to get it up on Zoom. All right, okay. So we have a technical hitch here, so we're gonna do something. So there you go. Now. And can I do I need to bring it up big on this one here, Nina? Yeah. Great. There you go. Okay, so that's super. Thank you for that. So many years ago, back as far as 2003, I looked at the mortality, the deaths of people with an intellectual disability, and I compared them to those mortality or deaths in the general population. And at that time, I showed that people were dying about 20 years earlier than the general population. So the longevity dividends that we're seeing was not transferring. Colleagues of mine have repeated that study back just 2 years ago, and we still see the same issues around premature mortality in this population and massive health inequities. So this is what we've been trying to do. Now, this here is a map of the world, and all those little dots are the longitudinal studies that have happened all over the world. And I've showed you the previous slide on the deaths, and I thought, how come not one country in the world has ever included people with an intellectual disability as part of the general aging studies? So that spoke for itself, didn't it? Like, we wanted to understand what the determinants of health and well-being were for all of us who are sitting here, who are perhaps well able to self-advocate around those issues. But for this population, we weren't. And I really formed a coalition of the willing. And that was people with an intellectual disability themselves, family members, and academics and other service providers. We had no money, Anya. It's the story of my life. We started with no money, like we did with the National Memory Clinic. But I thought, if the idea is good, money will follow. And it was a coalition of the willing, as I could describe it. And it was austerity biscuits, custard creams, and tea. And that's how we started. And I'm really pleased to say that we have launched the first longitudinal study, and now we're in its 15th year. And we have got continued funding from government and from the Health Research Board, and now a commitment that the data from IDS Tilde, I'm sorry, Lena, I'm continuously moving, that the data from IDS Tilde will drive evidence-informed policies. And that's really what we're trying to do. And I'm going to talk a little bit. And that's some of our participants, which means so much. And during my time as well, I thought there was 3 things we needed to do. I was very intentional about impact from the very beginning. I wasn't interested in just doing research and producing data for data's sake. And the types of impact I wanted was, I needed to get the human infrastructure in the field. I needed to get people who were interested in researching and working with people with an intellectual disability. And we've had about 20 PhDs graduate now from IDS Tilde. Isn't that amazing? So now we have massive infrastructure. I wanted to develop a centre within the university. And when I was faculty dean, I managed to convince everybody that we needed an academic centre to study ageing. And we have established that in the university. And then I wanted to develop and shape care and clinical services. And one of the clinical services that we've developed is the National Memory Clinic with Tallaght University Hospital. So I'll talk a little bit about that. So I was very intentional from the beginning. So just the objectives, and I'm not going to labour on these, is really to understand the characteristics of people aging with an intellectual disability, to examine the service needs and healthcare utilisation, and then to identify the disparities in their health compared to the general population with the data yielded by Tilde, and to support evidence-informed policies, practices, and evaluation. We've got to get this data to change care and to change the life outcomes for people with an intellectual disability. So as I said, we are the first longitudinal study in the world to have ever included people with ID in tandem with a general aging study. This is where people are selected from. In Ireland, we have what's called the National Intellectual Disability Database, which collates information of people with intellectual disability or need or receive services. I was able to get access to that database and randomly select 10% of the total intellectual disability population aged 40 years and over. Tilde is following people aged 50 and over, but because of premature aging in people with an intellectual disability, we needed to start earlier. So we started at 40. And there are the series of reports. And of course, in 2020, we were out in the field collecting data when COVID struck. And I marshaled the energy of my great team and really felt it was time to give back now to our community. So we had now years of really good data. I was able to get that data and to use that data to help inform needed responses to the COVID pandemic for people with an intellectual disability. So I had the evidence to understand who was likely to have poor outcomes should they get COVID, and those situations which put people at increased risk. I worked with Dr. Alison Hartnett in the National Federation of Voluntary Bodies, and we were able to use the IDS Tilde data to inform needed responses to deal with COVID for people with intellectual disability. And we got people really moved up the chain in terms of the vaccination program, but it was evidence and data driven. And with this data, we were able to drive that. This is the conceptual framework of the areas that we're collecting data on. And it's the same as Tilde. The areas in yellow are unique measures for people with an intellectual disability, simply because some of the measures for the general population wouldn't be suitable. But we also interviewed people with an intellectual disability themselves, and we asked them and their families, are there areas missing here that are really important in your lives? And the whole area there in the social domain around community participation, social connectedness, transitions, friendship, they all emerge and are unique to IDS Tilde. So what does it teach us? And I'm just giving you a little bit of a flavor. So this is looking at chronic health conditions. And you can see here the difference in some of these conditions. So we refreshed the sample in 2020. So you see existing participants is in the lighter blue and the new participants is in the darker blue. And the new participants obviously were younger because those aged 40 to 49 had aged out. So we needed then to replenish the sample there. But things that I want to highlight here, because these are things which are amenable, I think, to non-pharmacological interventions and are very distressing for this population. Very worrying prevalence of chronic constipation, and I'll talk a little bit about that, at almost at 48% in those aged 50 and over, and in new participants who are only mainly 40 to 49 at over 30%. We ask people, have you been diagnosed by your doctor with these conditions? In wave 2, I'm going to talk a little bit, we did objective measures of some of these conditions, and we're going to show you the difference between objective measures of health and that which people reported. So 26% said that they had osteoporosis over time. Very high level of emotional and psychiatric and mental health problems. And we've got to get under the bonnet as to why there is such mental distress in this population. And you know, how many of them are suffering from pain and other chronic conditions that they're simply not able to express. And the only way they can express this is through pain. And also a very high level of epilepsy, seizure activity in this population at 33%. And the prevalence of epilepsy in the general adult population is 1%. So you're looking at something here that's quite contrastingly different. But this is just showing you here the trends in chronic constipation. And what was really interesting was that the level of intellectual disability and mobility were significantly associated with constipation, but age wasn't. So that is very different to what we see in the general aging population. And what's really concerning was that 42% reported using laxatives. And out of those who are using laxative, 40% reported using 2 or more laxatives. And we also reported that factors associated with laxative use was increased anticholinergic burden and soft and liquidized food intake. So this is a major issue that we do need to look. There's a real opportunity here for a bowel intervention program for this population. This is Kevin and Myra Dwyer is leading out on some of that. This is a Kevin Igilifordrick, or Kev, and Kev did his PhD with us, and he's leading the oral health arm of IDS Tilde. And what does it tell us about oral health? And if I was to ask anybody here to smile or to think about the mouth and think about how important our teeth are to us all, and what it would be like to have no front teeth. I mean, just how we would feel about that. But what we reported was that 28% of participants with ID reported that they had no teeth at all. And this compared to 16.9% in the general population. But this is where the difference is. Almost 70%, 67.8% of people with an intellectual disability who had total tooth loss did not wear prosthetic dentures. So they were orally disabled. So they were completely edentulous And that was really quite a story. And this compared to 5.3% in the general population. So they were not likely to have restorative treatment, they were not likely to have dentures or implants, etc. And what we also showed that those who were aldentionists were twice as likely to have a difficulty in eating, no surprise to any of us here, 3 times more likely to be in a soft or liquidized fluid intake, and twice as likely to report chronic constipation. So you're seeing this cyclical issue for this population. There's a huge number of publications. Kev and his team have also developed now an accessible website to teach people how to brush their teeth, people with an intellectual disability and perhaps staff and family caregivers. This is Dr. Eilish Burke. Eilish also did her PhD with me, and you get the trend here. Eilish is now an assistant professor at Trinity, and she's leading the bone health and the physical health assessment arm. So we asked people across the waves, had you ever been diagnosed by your doctor with these diseases? And this was osteoporosis. And in wave 2, which is 16% reported that they have been diagnosed by the doctor. And I always say, much and all as us scientists might like to think that there's no intervention being a part of a longitudinal study, but you know there is, because when somebody asks you, oh, have you had your bones checked? You'd say, well, no, do I need them? So people move along. But the difference here is we did objective measures. So out of the group, and 14% then who had a doctor's diagnosis gave consent to have their bone health measured objectively. And what we found, an objective measurement uses the quantity field ultrasound scan. It's not the gold standard, we know the DEXA scan is, but it's what Tilda are using and other groups. We found that over 70% of people with an intellectual disability had poor bone health. 41% had osteoporosis and 33% osteopenia. I'm not talking about the rate of fractures, this was extremely high. Even those with multiple fractures didn't have a DEXA scan because it was too difficult for them. And there's loads of reasons that this population are predisposed to poor bone health or osteoporosis. And osteoporosis, as you know, is brittle bone. And many people can be walking around with, it's really a silent disease in many ways. And people can be walking around with a vertebral fracture or something similar and have no understanding. And for many people with an ID who are not able to self-complain about pain, they're more likely to prescribe a couple of tranquilizers or whatever else medications than appropriate pain medication. So these, when I say I'm trying to get under the bonnet as to why there's such levels of mental distress, the very first thing we have to do is be able to diagnose common diseases and understand what multiple morbidity looks like. Men were at significant risk of poor bone health. So 6% of the men that we looked at had reported a doctor's diagnosis, but 90% of them met objective measurement for poor bone health using the quantity field ultrasound. So men with an intellectual disability were 12 times more likely to have poor bone health than men in the general population. And most of them had no understanding about that. And again, there's a whole load of publications. I'll give you the website, you can download all of them yourselves. This is Dr. Myra Dwyer's work. Myra also did her PhD with us. These are getting the feel of building capacity. And Myra now is leading the medicine optimization arm of IDS Tilda, and she has got an academic position in the School of Pharmacy and Pharmaceutical Sciences at Trinity. And we looked at medication. So what we know is that 21% were what I meant, this has slipped a little bit, apologies about that, were reported non-polypharmacy, that's 0 to 4 medications. But we had a huge number, 31% that reported taking 5 to 9 medications, which is polypharmacy. But we also had 21% reporting taking excessive polypharmacy that's greater than 10 medications. So that was huge. So in Tilda, in the general population, we were looking at only 2% being exposed to greater than 10 medications versus 21% of those with an intellectual disability. And we were interested in looking at what were the drugs and the medication categories was driving this. And as you can see here, the drugs which were driving this excessive polypharmacy was antipsychotics, anti-epileptics, and laxatives. And a very different prescribing pattern than we see for the general population. We are more looking at the lipid modifying agents, the cardiovascular disease agents, antithrombolytic agents. So we were not seeing these within this population. So there's over-prescribing in some categories perhaps, and under-prescribing in other areas. So we gotta really try and get a handle on all of this. Now we have a great study now, which Myra's leading with the Royal College of Psychiatrists and the clinical lead in disability, really trying to develop stop-start criteria around and de-prescribing for this population. I want to talk a little bit about dementia and its related care issues. So this is taken, I have followed a population of people with Down syndrome, and I'm giving away my age now, but for 35 years, probably one of the longest longitudinal studies anywhere. And this here is taken from a 20-year follow-up that I reported looking at risk at age. So what we showed was that 23% of people with Down syndrome over the age of 50 were at risk of dementia. This increased to 45% at the age of 55 and 88% in those aged 65 and over. So the risk of dementia is extremely high. We also showed a very strong correlation. You can see here the red line and the blue line. The blue line is those developing dementia, and the red line is new onset epilepsy. And you can see here this linear correlation between the development of new onset epilepsy and the development of dementia. So about 80% of people with Down syndrome, when they develop Alzheimer's disease, will develop new onset seizures. And I could talk forever as to why we have this risk, etc. We know we have the risk, but we've got to be doing something to prevent it. People with Down syndrome are never included in clinical trials. They're not included in the disease modifying agents. So we've got to really look at bone health, our brain health, and move the dial. So this here is from IDS Tilda. And again, it just shows you the difference between ID. And this is Dr. Emer McGlinchey. Emer did a PhD with me as well. And she's a psychologist. And she's got an academic position now in Trinity. And she's leading the dementia-related arm. But you can see here that the odds of somebody with Down syndrome was about 10 times as likely as the odds of having dementia, but if you had an intellectual disability from other etiology. But this prevalence was lower than what we had reported in other research, and certainly in the other longitudinal studies, which I've been leading. But what we noted as well was that about 45% of the people in IDS Tilda who didn't have a diagnosis of dementia never had been assessed by the doctor. And many GPs literally lack the skill, they don't have the battery of instruments, they are falling between stools because their general memory clinic are saying, we only see people over 65, and these people are obviously, the mean age of onset of dementia, the Downs population is about 51 years. So they were falling between two stools and really very difficult. So there was a need then to develop a national memory clinic, and we got some seed funding, again, very little funding, through the dormant account fundings to pilot setting up a national memory clinic for people with intellectual disability. And we did this very successfully with Tallaght University Hospital and Avista, which is a large service provider providing people support for people with intellectual disability, where they had already a very well-established memory clinic and Trinity. So we came together, we joined forces, and we set up this national clinic. And I'm really pleased to say that after the pilot period, we now have got sustained funding from the HSE now to have this national memory clinic fully funded, which will mean that anybody with an intellectual disability anywhere in the country will no longer be out there falling between stools, screaming, looking for assistance or support. And we have Evelyn, who's one of our advanced nurse practitioners, and we have a number of advanced nurse practitioners who will be running that. And going forward, then we will be aiming then to develop satellite centres in other regions as well. So this is really, really exciting for people, and this is what we need to do with good data. And we are now looking, of course, we have set up Dementia Trials Ireland, which I'm also part of, and Professor Sean Kennelly is the clinical director of the National Memory Clinic here at Tallaght. And we have now Irishima Leroy has got funding to set up a national trials network. And of course, somebody like me is in the middle of that, making sure that people with ID are going to be included in any trials. And we have the infrastructure now with a national memory clinic to include people in trials. And I'm very connected here to this Horizon 21 consortium. It's a large European consortium where we're working together to try both to develop test instruments, standardized assessments across Europe, and also look at how we can do joint clinical trials across the country. And this is extremely exciting. We also have a very big caregiver arm to this study, which my colleague, Dr. Damien Brennan, is leading. And we have really, because many of these people now are aging with family carers. And what is going to happen to those people when they age? What we're seeing is a lot of sibling carers. There's very little planning. We have closed down many of the historic institutions, which is a good thing, that were there in the past, but we replaced them with nothing. So that is a huge issue. So the burden on family carers. So we are going to drive now, we're trying to drive now these issues for aging family carers and sibling carers with the data that we have coming out of this. We also had, we have a very large end of life arm to the study, because obviously mortality is one of the markers that we need to be looking at. I've just got, we have had over 200 people who are in the study who have passed away since we started. And I've just got access to the death data from the National Registry, and I'm going to be looking at that death data now because it's the most reliable way that we can really understand cause of death and contributing causes. And we held a lovely event at Trinity in December to mark those at the commemorative ceremony who had passed away, who were part of IDS Children. How my time was, am I okay? 2 more minutes, okay. So addressing difficulties in relation to healthcare access. And this was one of the things I really wanted to finish up, was that so many people with an intellectual disability found it really difficult to make themselves understood when they went to a healthcare professional. So only about 15% felt that they could make their needs known, and the rest found it really difficult. And that's why I think that the appointment of Suzanne at Tallaght University Hospital really is so critical, because she can be the bridge and the communication and the voice for that person, helping with and working with other healthcare professionals in the hospital to make sure that the needs of people are sought. And I would like to see that happening within primary care, Susan, that we would have a similar role, that we would have nurses there who could support busy GPs to understand what care needs were. And of course, we have the HSE healthcare passport. And this is really important that we are using this and completing this. But I want to give the last word to people with an intellectual disability themselves. And what we did with each wave, we have created, if you go on our website, we have Aging with Pride. It's a video which a lady, Mei-Lin Yap, she's working with me now at the centre. So we have people with ID working in the centre. And she has told the story of the 10 years of data. It's a lovely 15-minute film. But this is a short minute clip about people going to the doctor. I hope you enjoy this, and I hope it works.
Health services. In the IDS Children study, we asked people about using health services. We found out that people found it easy to speak to their friends. Most people found it hard to speak to their doctor or other health professionals. A lot of people had more than one health condition. A lot of people took more than 5 different types of tablets. Most people did not get easy to read health information. The following scene portrays some of these points.
I'm not feeling very bad. I'm not pain in the tummy.
Pain in the tummy.
Yeah. I am.
No, I'm not sick, 'cause I have to go to see the doctor, so we can't be perfected. My hearting and all the tablets I'm taking too much tablets.
Richard. Take a lot of tablets. Something we want to. I had problems with the doctor. I get scared.
It's good. Should everybody, should we all like the doctor? You know, we all like the doctor, because the doctor's very nice.
I can't understand what he's saying.
He's saying he's talking to me.
It's not like talking to his friends, it's hard talking to the doctor.
Next, please.
How do you stay with it? Okay.
You get tired a lot.
Yeah.
I take your tablet
Okay.
and go listen to your heart rhythm.
Okay.
That's good for me. How's your back today, Rita?
Okay.
How's it walking?
Okay.
Anything else I had you do it?
No.
No? I give this tip to you. Healthy eating.
Thank you.
Bye, Rita.
Bye.
And who you go on? Again. Somebody.
I'm too scared to ask them.
Yeah,
Then it's supposed to read, but I can't read.
tell me.
Okay, I think that is a story probably that tells some of the struggles, I suppose, and things that we need to try to get a little bit better at and try to change. And lastly, I just want to remember Maggie. Maggie was a patron of our study since it started, and Maggie passed away last week, and she was in her 98th year. And she has lived in an institution all of her life. And even when it came to moving from the institution, she bolted down hatchets and she said, I'm not doing it to suit policy. I've lived here all my life. I'm really happy here. This is my home, and I refuse to leave. But I did want to remember Maggie. I thought it was very befitting. And just to thank the team and the funders. So hopefully you found that of some interest and use. So thank you.
That really was wonderful. Thank you. While Aine is setting up maybe the next set of slides, does anyone have one quick question for Mary before we move on to the next?
Just look, the GP, I deal with a special needs girl, right? And we go to 11 doctors, and there's no connection between them. And then there's no, the GP, like, 1 week is for ear, the next, and her ear is very bad, the next week is for brow, the next week.
There's no, yeah, there's none. And you see, we have not developed you know, in the Netherlands, for instance, and some other countries, we have gerontologists who are specifically expert on dealing with people with an intellectual disability, but there's no specialist training here, you know, so there is nobody the kind of who's looking after the totality of the individual, of the person. And that is one of the issues. And that's why we need much more nurses who can navigate the system for the like of yourself, bring all of these professionals together so as that you as a family member or your daughter are not lost between two. And often these systems don't speak to each other. And you're absolutely right about that. And they don't speak to each other. So
Then you know the way you talked about the tooth being missing.
yeah,
Somebody, most of the people that I've worked with in that area, they need a reminder because that tooth will be lost tomorrow. You know, it'll be there today. And where did I put it? I can't remember. I was in the bathroom.
but sure, you know, as we're all getting older, we're trying now, you see, we're trying now not to have too many mobile pieces attached to it, if at all possible. And really, for this population, which find it difficult to manage dentures, we should be looking at implants, because implants is something that we would be using for me and you.
Yeah.
So
Brilliant. Okay, we'll move on to the next speaker if that's okay, and then we'll have time at the end for some discussion.
and I will be here.
Yeah. So Sinead, do you want to go ahead, please? So Sinead is our community representative, as I introduced her earlier, so she's here now.
Hi everyone, my name is Sinead Tighe. I work in the Tallaght Community Council as the inclusion officer. I'm a mum. I'm a mum to Shauna, who's 18, and I'm a mum and advocate and carer to my son Daniel, who's 15. Daniel was born with a condition called Soto syndrome, which is a rare genetic disorder. So basically it poses to have severe intellectual disability, lots of issues, but the main thing is he's non-verbal incontinent. He aspirates on fluid, so he's peg fed. He has epilepsy. He's a few little medical issues, but the major thing in dealing with Daniel on a day-to-day basis is he has behaviours that challenge. So that's the hardest thing when we come into care and going to see the doctor or going to hospitals. When we started off our journey with Daniel, we would have started between the two hospitals, which was Tallaght Hospital and Crumlin Hospital. And that was kind of daunting, and it was easy enough to navigate, I have to say, but daunting the way I didn't know what was ahead of me, but easy to navigate because I was with new mums, so we were all the same. Even though my child I knew was different, I was still in that form of new mums, and Daniel didn't stand out. So he was in a pram, he was in a buggy, so generally the things were going okay. As time moved on, we got up to the age of 5 and 6, and Daniel was in a wheelchair. That's when my life started to change quite slightly going into care, because I had to navigate down narrow corridors. I'd be sitting in a long corridor waiting, and Daniel's behaviour wouldn't be good. He'd be screaming, he'd be banging his head. And I would be sitting there for 1 hour waiting, and no one would come to me. And it was very stressful for me as a parent, but more and more stressful for Daniel. And me trying to explain to nurses and to parents beside me that this was Dan was very, very hard. And often I was just put into a room, a very small room with Dan. And that was very, very upsetting for me. It became over time then, I'm saying this has to change. How will it change? And it can only change through my voice because Daniel doesn't talk. So I began to talk to each and every doctor about Daniel, trying to say to them, please think outside the box for my son in relation to care. But everything kept falling on deaf ears. No matter what appointment I came to, I was still coming up to the battle of left corridors, left long hours, left waiting, not given you're not saying preferential treatment, but to understand Daniel that he needed to have maybe be seen. If I was going to 9:30, yes, Daniel had to be seen. So where here's Dan, he was going to be in today, has to be seen in and out. We did started to get that going because as Daniel started to get older, behaviour was getting much worse. So he was upsetting people in the waiting rooms, as much as upsetting his mother. But if then what was happening, Daniel was turning his behaviour onto me. So he started to hit and lash out at me. But then when he'd go into the doctors, he would hit and lash out with them. So it meant the longer he was kept waiting, he wasn't in any fit state for an assessment in the way, when he went into the doctor. So you go in and they'd say, what's wrong with him? And you'd look and say, seriously, you're after leaving me waiting, what can we do? So that was a major issue for me, and still a major issue for me, is trying them to get to understand Daniel. So, trying to understand how to manage him, how to assess him. And I email them in, say when I have an appointment, I email in about all his issues. But I know I could be emailing a nurse and that nurse may not be on that day. And I have very, very good relationships with all the nurses and the doctors, but not necessarily if you're going for a blood test, did that information be sent over about how we're going to manage Daniel for his blood tests. So I find then there's a lot of information that's lost that we're trying to give. So what way can we make that better? Is there a way I can put on Daniel's file? Is there something we can put on Daniel's file to say this child has challenging behaviour and we need to think before we bring him in for an appointment? What do we need to do for Dan? And like many other children, what do we need to do? And I think one thing that doctors and nurses and GPs need to remember, that one size does not fit all. Each and every child with an intellectual disability or with autism are different. So no two practices are the same. So the person that you're going to really have to talk to is their carer, their mum, or if their sibling is caring, is to talk to them and find out what way do we need to meet with this child? What do you need? I need a very large room. I don't need six nurses in. I need two. I need two that could cope. I need two that understand. And that's lacking because we have general nursing population. You can't expect them to understand a child with intellectual disability. They're very, very good. They're caring and that's their profession. But if they haven't got the trained skill to understand a child with challenging behaviour and how to work with them, that I have learned being his mother, and if they don't have it, how can it work? It can't be a good, it's not good, you know, it won't work out well. But when we have intellectual disability nurses, if they were working with us, well, then they have the more understanding of how the approach should work. You know, as the child, Daniel is 15 now, and he's going into adult services. That's a huge transition for us now, moving from pediatric, where we are very minded and we have a very good relationships, but we're going into where we're not going to have the lead pediatrician looking after us. We're left on our own. So it's me GP. So my GP will be filtering through the hospital. So I've already started to look at and see how can I make this transition for Daniel. I've spoken to the doctors. I've asked them, can you tell me who Daniel will have when he goes into adults for neurology, for orthopedics, for looking after his constipation, for looking after his dietitian? Can you find that out for me? Can you then allow Daniel and I meet these doctors so that they can meet Daniel? I want them to understand my son. I want them to understand how difficult it is going to be to assess him and what may they need to do to assess him or to help him medically. My concern as he's getting older will be that, will he get the proper care? Will he be looked after well? You know what I mean? What's going to happen to him if he doesn't get the proper care? You know, because he challenges doctors. He lashes out, and I have actually measured his arms. I have done everything to tell them stand back, which is 65 centimeters, stand back, and then let him get to know you, and then I'll guide you in how to maybe come into him slowly, but I'll also guide you to step back out very quickly when I know the changes in his face. So we as parents, we understand our child, and if the child can't express then to a doctor how they're feeling, we as the parents are the ones that have to have the partnership with the doctors and the GPs, and that needs to happen. You know, also when you go into hospitals, it's not kind of really set up if you're on this staying overnight. You know, Daniel's in a hospital bed like everyone else, but they're all metal sides. So if he has behaviour bag in his head, there's no padding, there's no anything for me there to protect him in hospital. And that's for lots of children. So you end up asking for extra pillows and you're trying to put them up. So again, you as the parent are looking after the care, but the hospital who you believe should be caring for your child or the doctor is not having the service or not having the equipment there to care for your child. We could go into all the sections. You know, we deal with dental, we deal with, you know, orthopedics, we deal with vision, we deal with, you know, general stuff, and each and every one of them lack that little bit of skill to deal with people with intellectual disability. And again, you know, you meet very good ones, and they do actually just, when they do sit down and talk to you and say, Sinead, what do you need? Then we can kind of get a pathway of how to care for Daniel. It can't be that everything has to be done for Daniel under general anesthetic. That's not what I don't want. And that's what's been happening with Daniel. And I don't want that going forward. That's not good for his health. But I want to say, well, how he has a right to be cared for, but how do we care for him properly? And will you listen to us and form these partnerships with parents and with carers? We aren't the ones, we understand their care. We know what they need, but we're not there to kind of look negatively on the health system. We want to work and say, how can we together make this better? And I think lots of more parents are needed to be, we need to be spoken to when new things are happening. I had a very lucky I was to go over to the Glasgow hospital with Daniel, and it was the new Glasgow hospital. And when I went into this lovely area, I have to say it was so bright, you know, this huge waiting rooms and these just lovely padded chairs everywhere. So there wasn't any corridors, and it was just, you could sit anywhere and a child could be anywhere. So what I then noticed, I was going to be seeing 6 doctors. So I thought, oh my God, this is going to be horrific. It wasn't, because I went to a big room and those six doctors sat around and listened to me. And then each and every one of them asked me questions. And then they sat with Daniel and they spoke. And then we went in with a play therapist and they watched through a video of Daniel with me and seeing all the issues and seeing things that I could be able to show them, with Daniel being very, very calm. So they could see different things about his vision. They could see his movement. They could see what he could and couldn't do. And then they could make the assessment on that. So then I came back out and that wasn't stressful at all. So if certain hospitals can think of that, how they thought about, they knew Daniel was going to be challenging. So how can we do that? So it was brilliant to be doing it under video, to be able to me to be his mom and show all you want to do is show him in his good light, show what he can do and when he is in good form. You don't want them to be putting their eyes up to heaven going, oh my God, here's Dan again, and how hard it is, because the anxiety that's in me as a parent going into a hospital appointment, that often when I get to the doctor, they say to me, are you all right? And I'd say, no, I'm really going to pass out peacefully, because one, I'm thinking, did I get him in here right? Did I find my parking? Did I get in right? Where am I going to be sitting? What's the time going to be like? So all of that, it needs to be addressed. The other area that's in my family is I'm a sister with autism and mental health. And that's a major gap, as in we don't have intellectual disability nurses within this sector as well, working with the mental health teams. And when someone has autism and mental health, you know, the general nurses, they can't work with them, because if they're not communicating properly, or they have lots of issues about, as you've seen up on the video, about talk and how they find it different to talk to doctors, and they're scared, very anxious when they're going for appointments, that's a major gap, and that needs to be sorted as well. These are the things that I see all the time out there, and I talk to lots of parents that we speak about the care. And I think the most concerning thing for us is when they're getting older, how are we going to care for them, or how can we work the care within hospitals and our GPs? It does all come down to communication, and that's great. We can communicate it, but then we have to kind of pull it apart a bit more, as in, well, now how can we make it better for everyone to work? Because you want the doctors to be able to assess, and you want the person that's been assessed to feel comfortable, and also that they are getting the care. You know, the greatest thing that Daniel has given me is to be his advocate, but it is also to see the other side of life when it is harder and when you don't have a voice, that the voice, how they deserve the quality of life, how do you get them to have the quality of life? And I have to be his voice. I have to share that, but it's getting that understanding from the doctors that I am his voice, and that this is all I want for the care for Daniel to be 100% for him always, within services across the board. You know, I won't talk about all the health services and the lack of services that are out there. And I suppose anyone that has anyone with disabilities or autism, or even anyone that's aging in elderly, will realise the services of care and all are lacking. But when it comes down to your general well-being, I think that needs, the first foremost, needs to be done right. That everyone deserves that quality of care, whether they have an intellectual disability or, you know, you're just a normal person within the hospital settings, that we both need the same, and the quality of life is what they need. So that's all I kind of have to say today. That's the gaps that I see, and they need to be addressed, and we need to have a better partnership going forward, working with care.
Thank you very much. I think we could listen to you all afternoon. You are an incredible advocate and a voice for Daniel. So well done. Yes, brilliant. So we just have one more short presentation, and then we'll try and have a group discussion. And I'm aware if there's anyone online who wants to put in any questions into the chat, we'll take them as well. So maybe you might need to just set up. So next up we have Suzanne. Did you want to say something very quickly to introduce Suzanne on your? Yeah. Just while we're opening up the slides.
Good afternoon, everyone. My name is Aine, Lynch, Director of Nursing in Tallaght University Hospital. Just checking you can hear me okay over there. And I'm delighted, Sinead, thank you very much for that really powerful story about Daniel and your experience. And I hope that particularly when Daniel moves into the adult setting, that we will be able to provide work with you and partner with you and Daniel to provide a better experience. And I think Suzanne will share now her role in Tallaght University Hospital on the adult side and how we've managed to carve that piece out and enhance patient experience. Just I'd like to acknowledge the Dr. Dershaw in the ONMSD and Sheila Cahalan, Director of the NMPTU, for putting the funding in place for Suzanne to assume the role. And I'd like to acknowledge my colleagues in Cheeverstown, Sandra O'Reilly and Denise Fahy, who had a vision in partnership with the NMPTU to put this position in place. So I hope you enjoy Suzanne's presentation and thank you very much.
Afternoon, everyone. Thank you, Anya. My name is Suzanne, as Anya has said, and I am the Intellectual Disability Liaison Nurse in Tallaght Hospital. So my role, I go this way, do I? Keyboard and down. Yeah. So the background to my role is, Dudi Adal is a young man who has identified the need for innovation in intellectual disability healthcare, requiring RNIDs, registered nurse in intellectual disability. That's my discipline. To support people with an ID within all areas of healthcare delivery, for example, in the acute hospitals like Tallaght, mental health care services and primary care services. So the intellectual disability nurse liaison role was set up in response to recommendation 8 of Shaping the Future. So Shaping the Future of Intellectual Disability Nursing was a document that came out in 2018. There was 32 recommendations in all. Recommendation 8 is the introduction of intellectual disability liaison nurses in the acute setting. And RNIDs are a key profession in the delivery of health and social care supports for people with an intellectual disability. So a very quick synopsis of how my day runs. A referral is made either through the Symphony flag. So in the emergency department, there is Synergy and the Symphony flag. So Symphony is the program that's in this hospital at the moment, and we've created a consult role up on the system so that they can ask for consult for the intellectual disability liaison nurse. Synergy is the Symphony. I always get the two of them mixed up. I wish they had picked different names. The Synergy program is the new IT infrastructure that's there. The Symphony is the flag. So when a person with an intellectual disability comes to the emergency department reception, if they say that they have an intellectual disability or their carer says that they have an intellectual disability, I do ask that people make that known. There's a flag put on the system in order so that when I go in and I can check the system, I can see it's a small little blue eye. That's all it is. You can email me, you can phone me, you can bleep me, and for outpatient appointments, inpatient schedule care, and support everybody. So what we look at first of all is the presenting health issue, so the presenting problem that the person comes in with. I either attend the ED, service user in the ward, anywhere that they are in the hospital. And part of this piece is the building the knowledge. So what we need to do is work with Sinead and Sinead's counterparts and work and build the knowledge on how we can best support the person. So that's what I do. We discuss the challenges and then we make the interventions. So the interventions are the reasonable adjustments that you or I, my role in itself is a reasonable adjustment for a person that's coming into the hospital. Reasonable adjustments can be longer waiting times, shorter waiting times, be first on the list, be last on the list, have a space on their own, have a sensory space that's tailored to their needs, have easy read documentation that's there ready for them so that we can explain the process of what's going to happen. What I've done in the last 2 weeks, for instance, we've developed tailor-made social stories so that the person who comes to the appointment can see the picture of the doctor that they're coming to see. They can see what they're going to talk about. They can explain the plan and that we can have the support staff there ready to go, understanding what the expectation of the appointment and the person is supported home. Quick, simple, easy. As Evelyn and I just said, it is not rocket science. It really isn't. It's simple structures that we set up and we do well. What we have to do is set up the structures, have the database there with the easy reads on them, have the services in the community, have the GPs in the community, like they were saying earlier, ready to go and understand and join the networks. And what we don't have at the moment is any networks joined. They don't talk to one another. They don't understand someone else's difficulty or challenge when they come in and see them. They don't understand it. And our job, or my job, is to build that knowledge. So I can, when a person is in the hospital, I can refer to the acute supports. I meet with the clinicians, I meet with the psychiatrists, I meet with the dietitians, nutritionists, and explain from the carer's point of view, from the person's point of view, the challenges that they have, either being an inpatient, an outpatient, or a member with an intellectual disability in the community. My job is to build the capacity of the hospital staff so that they have better awareness and better understanding and better experiences. That is working, that is happening. They are grateful to see you coming. They don't realize, they don't know how to support a person until they're in the situation. They don't know how to do it until, because every person's experience is so different and so varied, and every individual is so varied that they can't be taught everything at the same time. So it's only through experience that I learn. So build the capacity of the hospital staff to assist with investigations so that we don't have general anesthetics for every procedure, so that we have pathways, that we have support structures in order to get somebody to have an MRI. We had a person in AMU recently who was supposed to go for an MRI. The porter came down and said, "I'm here to bring you for your MRI." The person went, "I'm not going anywhere with you." And the slot was missing from the MRI. So we were a full 5 days waiting for the next MRI. That person remained in hospital for a full 5 days waiting on the next slot. And that was because the person wasn't given enough time, wasn't given enough opportunity to allow to understand what was being asked of them. That's my job. We built that capacity. The person went to MRI without any issues after that. The link between the acute MDT and community MDT, so that speaks for itself. I can join the two teams from one side to the other. I'm involved in care plan meetings, discharge planning, and eventually transitions home. That's the day-to-day running of the service. Okay, two very short synopses. John, young man, came into ED last week, autistic, has anxiety, and his challenge was listening to anybody clearing their throat. How do I prevent that? I can't prevent that. His team can't prevent that. So he has a staff with him all the time. He wears ear defenders. And how would you support that? He had a very bad cellulitis in his leg, swollen, really struggled with that. The first time he came, he had the antibiotics. They said, "No, we'll send him home because he's going to struggle with being here in the hospital." He ended up back 4 days later. He shouldn't have been. We should have encouraged him to stay home. The second time he came back, admitted with IV antibiotics, connected with between his hospital staff, his community staff, the staff that were coming in to support him, the ward staff, everything. 3 days he was home again with a better understanding, with a healthy eating connection, with a better understanding of and control over his own healthcare because he had the ability to do that. Monday, I had a 51-year-old woman in for a scheduled procedure. She's 51, she's over 18. Consent policy indicates that nobody has the right to consent to a procedure on her behalf once she's over 18. However, she doesn't have the capacity or the full understanding to understand what the procedure is or give full consent. So I had a phone call from the clinician, I had a phone call from the mother, I had a phone call from the service. We were able to reconcile everybody with giving them the information that was in the national consent policy, giving the team working with them while they were stepping in and out of theatre, the parent themselves making a phone call to the parent, and the service and the nursing staff. That procedure, the person was understanding. We allowed the fact that the person was coming to the hospital, was interested and had a certain amount of awareness that we were there to make a plan to make it better for her. I was able to ask her that. She was able to indicate that she understood that, but she didn't understand anything else after that regarding her consent. She procedure, admitted to the ward. I shared the documents. She went to the ward, had recovery from her procedure and home the next day. Successful procedure. We didn't have any issues with that one. So we're working on a sensory space in the emergency department. So hopefully we'll have that. HSE Health Passport. I'm a point of contact for families. The link with community services supports and will prevent readmissions to the acute setting. That's the aim. Everybody come in, but we want to get you home as quick as we can. And these are the education sessions and podcasts for TUH, hopefully this summer. Alert on the hospital IT system to inform of reasonable adjustments. That's really where we want to make that happen, to inform what Daniel needs to support his time in hospital. Easy read documents and outpatient letters, a database in TUH for easy reads and picture menus. And that is a leaflet of my service. Thank you. Very short.
Thank you very much. You shared a lot of information with us in a very short period of time. No, you did it very, very clearly and very well. Thank you. I might just invite the panelists up to the front, and then if we have any questions, we'll take them. I'm conscious that we are running late, and I'm sorry if there are people online who may have to go on to other meetings, but we're going to maybe go on for another 5 or 10 minutes here, if that's all right. We have our cup of tea. So if you all want to grab a seat, and Mary, you're going to come up as well, please. Brilliant. So does anyone here want to ask any questions of anyone on the panel to kick us off? And I'll just check the Lena, you can let us know if there's any questions from people at home or in the office or wherever they are. Anyone like to kick off with any question?
It's not a question, but it's a comment. You mentioned about the person who's not prepared to know about the MRI. It's quite nervous on it. That does not only apply to people with disabilities. Yep. I'm sure everyone here can tell a story of somebody in their family.
Yeah, and I agree. It is really the communication piece for anybody who is in hospital is really important. So when I arrived at the hospital, there are certainly lots of elements of hospital life that don't suit everybody. So English not being their first language, not being hard of hearing, mask wearing, all of those elements are a real challenge for people. My role is to support people with an intellectual disability. However, it's across the board, it will have an effect across the board. If we had supportive documentation for the nursing staff to be able to explain to a person, this is the process, this is what it looks like, the understanding of what the phrase MRI means. Yeah.
And indeed, in the memory clinic that we run upstairs, we support an awful lot of people with intellectual disability and dementia, and we have developed those documents to show and to explain to a person in very simple terms what is involved in a brain scan or an MRI scan, and it is working out very well. Yeah,
That's just Tallaght.
that's just here, yes.
You know, that's more back.
I suspect, you know, so it's funny, sometimes as a GP, I actually look up the patient information leaflet for something because I think that it might be useful for the system, for that information to be spread more widely, you know, because you're such communication experts because you've had to make an extra effort that it probably will have much wider use.
If you design for disability, you design for the rest of society.
Yeah.
And that's designing in everything.
And I do think is not to be afraid, like, you know, doctors not to be afraid to ask parents questions or ask, you know, what can they do to make things better. They don't just think because you're a doctor, you can't really come down to that level. You know, I work with a very good GP, and, you know, I got a phone call from him 6 months ago in a panic, and I said, what's wrong with you? And he said, Daniel, it's 15. And I said, yeah, I know. Why are you panicking? I'm panicking. Why are you panicking? And he said, oh no, Sinead is going to move into adults. And straight away he was thinking of me. And I said, what do you want me to do? And he says, can you do a report on Daniel now on everything that he's getting? And I want to see where I fit, because his care will go to him. But also what he wants to make sure is that, can he give Daniel that care? Or is there something better for Daniel out there? So that's what we're discussing. You know, is his setting the best for Daniel going forward? So if that's broached now at 15, at least when I get to 18, I know what's going to happen. And if it's not that GP, it's going to be somewhere else that we've sorted and assessed, and it's better for that, you know.
Yes.
I'm one of the shy men who came here today. And I happen to be with a men's shed. And on one occasion, we decided that we would have an official launch. And we went through all the different members. And up until then, I was with those people for 1 or 2 years at meetings and this, that, and the other. Never knew any of them until they opened up in front of a group and admitted. And here I compliment Professor for your vocal presentation was so clear that it's a gift that some people have and you have it. But anyway, with me I'm only, anyway, I'm one of the younger ones here. But, I have had all the different things that you mentioned. The intellectual disability, I'm still not sure whether I have it or I haven't. But the doctor told me that it would be diagnosed if I, anyway. But memory loss, definitely. Constipation, definitely. Hypertension for blood pressure. Yes, I've had ear problems because that lady there, I find it hard. I have to sort of get a little extra light. Eyes, dry eyes, all of the different things at 83 years of age you have. And you end up in a situation where all my best pals, my 4 of a group of pals, I'm the only one left of the 4. I've lost 2 wives. And we have, I would love to be a member of your guinea pig team. And, that's all I can say. But basically, men should be here. And for some crazy reason, we don't. Women talk to one another, and as one of the mottos of Men Shed, we talk beside one another. We don't get to the nitty gritty of what happened last night. How did you get on? We don't tell. And as a result, I leave it to the panel to say whether or not I have this thing called intellectual disability.
Well, as I say, we're all getting older. It's not what condition you're going to get, but it's how many and what combination. And I'm slowly realizing that myself. So but yeah, what you're saying is completely so true. And I mean, yeah, everything you said is absolutely.
I think it gives us a good idea maybe for one of the talks for next year is this issue of trying to make sure everybody gets a voice and gets represented. And we
have a question or a comment, and maybe Anya might be able to talk about it a bit. And it'd be fantastic if the pediatric team, ID team at Tallaght could liaise with the adult ID services at Tallaght to support the transitions. So just kind of what kind of transitional support is there?
Okay, thank you, Rima. So just to clarify, so I know everyone here in the audience is very familiar with Tallaght University Hospital, and the National Children's Hospital have been part of that up until last January. So now we have Children's Health Ireland. So we're co-located and we share some services. So it's a different governance structure. So absolutely, Lena, while Suzanne is closely connected to the adult side at the moment, we work very closely with our colleagues in Children's Health Ireland, and certainly, you know, that would be the vision that we're already, I suppose, considering a transition type coordinator for children who are moving into the adult setting across multiple sectors. So it's complex, but it's something that I was just talking to Suzanne about that on the way over. And we're actively exploring that at the moment, because I know it's a time that can be full of anxiety for families. And one thing I would like to say, actually, we had, I got to know someone through I also oversee the patient advice and liaison service, which is feedback to the hospital. So we get lots of very good feedback, and we do get feedback when people are not happy with the service that they've received for different reasons. And I got to know a particular family who have a child with an intellectual disability. And as a result of engaging through that process, we were able to put a lot of reasonable accommodations in place for that individual. So now I must say his experience with us is very positive, and you know that's worked very well. So it's something absolutely that I'm mindful, and I know my colleagues in CHI, it's definitely something we will work with together.
It's a huge issue across all conditions. I know just as a GP for, parents of children with diabetes, with lots of other things.
I do
It's
think
very-
it's down to sharing of information.
Yeah.
I think that's really
Yeah.
the thing. And as we say, the link between GP and
Yeah.
maybe the doctors, it doesn't happen. Our services definitely
Yeah.
doesn't happen.
Yeah.
So I think it is the sharing of information. And if we have it all together, but then we have a very holistic approach to the care of that person. And that's what's missing. It's not that the care isn't there. It's about how to join it all
Yeah.
together for the patient.
It's very-
That's what
yeah.
the key thing is.
It's so fragmented at the moment.
Yeah,
And even
yeah.
if you have a summary care record yourself, that would at least give everyone else the information.
I know, but it's like as if I'm doing up all these little reports and, and I'm handing them to the doctors or I'm emailing them all this. I'm trying to manage the care and making sure you get all the information. Everyone gets the information. You're just holding all these files and making sure you're photocopying stuff, sending packs in. You have all from the baby up to this, like how.
Heavy responsibility.
On the care, on the parents, it's heavy for us.
And
trying to keep it
not
going.
every parent can do that.
No,
I mean, that's an
exactly.
extraordinary work you're
It's
doing.
like, it's like what Suzanne said, when the language barriers, they're
Yeah.
not knowing our health system,
Yeah.
how it works.
Hearing,
Definitely now with Ukrainians, they're not knowing
Yeah.
how our system works and being handed medical cards, don't know what to do with them. They have to sign up to a GP, didn't know any of that.
Yeah.
So like, imagine at that level, is that the same for people out there in our country that we don't know about? And they're not there, they haven't got the voice. So
Yeah.
where can we kind of get the balance right there?
Yeah, absolutely. We probably have time for one more question and then we'll wrap up, aren't you?
Yeah, can I just ask a question maybe to Mary? Like you've been involved in this for so long, and do you see light ahead at the end of the tunnel? Is it an optimistic outlook that we're looking at? Do you see a lot of changes maybe since when you started working in this area to where we are now and the positive direction we're going? And I suppose, is there optimism ahead for all the changes that are
Absolutely.
needed?
I think that's a really good question. I really am very optimistic because we now have people who are developing an interest in this area. The conversation has opened up. It was getting that conversation up. We have families now who are becoming involved in advocating and in speaking out. But I think we have, like the example here of Tallaght University Hospital, we have developed these liaison boards. I was the person who led the Shaping the Healthier Future report and wrote that report and headed up that because I thought we've got to have nurses doing the right thing in the right place. And these nurses are needed in primary care, they're needed in the adult hospital, and they're needed there to navigate the system for people. I actually do feel very hopeful. I genuinely do, because I think we, even it's pockets and it's smaller pockets, but there are people who are interested and are getting voice. And I think that will be good. We still have a lot of work to do, but I think if we could bring what has happened in Tallaght to Blanchardstown, to James's, to Kerry, to Cork, it would just mean so much. And I say we have to eat the elephant in small bites. and I think but I do genuinely feel, and people like yourself, just amazing. And I do feel.
You can see progression, but you definitely can see where things have fallen down, and new systems now being put in place aren't working. You can see that, and I think that falls hard on parents the whole time. When you're trying a new system and it doesn't work, or you're making a new system and the staff isn't there. So when you're making a new system, you need to have the staff.
Progressive disabilities and stuff like that.
That progressive disability is huge, and it's not happening. It's not happening. So if hospitals are progressing and doing that, where is the backside of progressive disabilities to back up that?
I know.
And then that's how youth can progress further if you don't have the backup from that side.
Yeah. Listen, thank you very much. It's we really could go on all afternoon. I think it's it's really important. And thank you all. And I think with everyone in Ireland will learn, we just need to hear about these, examples of excellence. And then it can move out into the rest of the system as well. So thank you very much. Lena, did you have anything you wanted to do at the end? Yes, sure. Yeah. You've introduced them all.
Yeah, can I just say, I've been involved with the APCC for the last year, and Sinead and Imelda have been our community reps, and they come to sometimes long meetings and they're very engaged, and they offer the community voice where it's really, really so important. And just as a little token of our thanks for all your work during the year, can we get you to come up, because we just got you a little bunch of flowers. One for Sinead. Imelda.
Wow.
Yeah, it was the most daunting thing to go on this. And I thought, would I match intelligence for this? And the first few weeks, I think I was a mute and didn't want to say anything. But then I found my little way. And then I realized that this, was so good. And meeting doctors and meeting nurses of the caliber that they were. I could see the vision for Tallaght that they had for care. But also working with Imelda and realizing, being part of the community of Tallaght is the main, most important thing. We're trying to make it better and keep it better. Yeah. And Imelda did a great job in that. So it was great to meet. I think you as well.
Thank you so much, Lena. So it's the Public Participation Network, the PPN. I was learning all the letters. PPN that we're on, and then we're on the APCC, Primary Care Centre. So I was learning all the letters first, and then attended the meeting, say, over a year ago. And like that with Sinead, it was like professor and this and doctor so. I said, we're just like, okay, just have a listen. But one thing I would say that I find was everybody was so welcome. Yeah, everybody was just so orderly and just talked about, whatever, and you really felt part of it.
It was very energized. It wasn't ever flat. It was very energized the whole time, which was really good. It wasn't kind of, everyone had passion and energized the groups and the way we went, the sessions with tangent, the different things. It was really energized. So it was great to be part of it. I think carer to give you something else and to be part of it and share your experience was really great.
I'd really like to thank Lena. Because when we kind of set up the talks, which was with Lena and Professor McCarron and myself and Sinead, and it was Lena was doing a lot of the work. I was providing the audience every session. So the U3A group have attended all the sessions, online, in person, whatever, through COVID, everything. So I have to say thank you to all of them as well. And I think that they have learned a lot as well. Really, for me, I was explaining to the group about what the APCC is about, and also about the centre here. And it was really, really lovely to be able to come here and see the building and to see what goes on here. And you just felt part of it. Well, I hope everybody did. So that's what the group is talking about. So, here to spread the word. So they're all about lifelong learning. So I think that was the screen usually goes up on your face. Just to say, anyone who's in the